Hello everyone. Today's topic is amoebic liver abscess. So, as I have already discussed with you that how the amoebias is spread, how it leads to invasion in the intestine. Now, it is the extraintestinal manifestation. So, let me tell you that is a very important thing. That is, it is the most common extraintestinal presentation, and it presents in 8 to 10% of the affected people. It is the commonest extra intestinal presentation affects 8 to 10% of people, hence also known as tropical abscess. Is also known as tropical abscess. It is important to remember. Infection commonly occurs from the cecum as the effect of amoebic typhlitis occur, and through the superior mesenteric vein and portal vein it comes into the liver. That is, for example, when we draw a diagram, we can appreciate over here that this is my liver, and through the mesenteric and superior mesenteric and uh, portal vein it comes to okay. So this this will be my superior mesenteric vein taking blood from the cecum, appendix and the adjoining areas, and this is joined with this splenic vein over here. Everyone knows the anatomy. And the inferior mesenteric vein also joins the splenic vein. The superior and inferior have anywhere if any infection will be there. It travels through this, okay, and leads to spread. This is spleen. Okay, so the infection mainly travels through superior mesenteric and inferior mesenteric veins, like this, like this, like this, like this, like this, and directly over here. Now, the most common site in liver, common site in liver where the abscess occurs is the segment number 8, segment 8. Why it occurs in the segment 8 only, or the right lobe over the posterior superior surface is segment. I will also tell you the segmental anatomy of the liver. Posterior superior part of the right lobe, right lobe. Okay, why it occurs over here? Because of the streamline flow of the portal veins. After the portal vein, the streamline flow of the blood directly to the posterior superior surface of the right lobe is the reason behind it, the only reason. Okay, so it affects this part of the liver mainly. Okay, streamline effect and the large size of the right lobe. Two reasons for this are because of streamline line flow of blood and number second, large size of the liver over that area. Okay, so when it the trophozoites reaches the liver, it firstly destroy the hepatocytes. Destruction of hepatocytes occur. Destruction of hepatocytes by histiolysin. Trophozoites release histiolysin. 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 Okay. So what trophozoite is releasing? Histiolysin. So this is if my trophozoite, bad looking guy. What is going to release? Histiolysin. Histio histiolysin and destroy the histiocytes. And a cytolytic agent, it causes amoebic hepatitis with multiple microabscess formation and liquefaction, necrosis, thrombosis. And these breaking the red cells and histiocytes led to production of a special type of sauce known as anqui sauce, which is we are listening or from our high school level also, that an anqui sauce is the feature, or chocolate brown sauce is a feature of amoebic liver abscess. It may be green sometimes if the it is mixed with bile, or maybe due to secondary infections it may be green. Okay, so that doesn't matter, but it is a typical presentation of the maybe liver abscesses and qui sauce. Okay, so this is the reason. So this is how it presents. Now we will go inside the complications. If once the maybe liver abscess occurs, how it affects the other organs, or the composition of this chocolate color abscess. First we have to look the pus produced due to destruction of liver parenchyma is sauce composition. What, why it is like that, why it is different from other pus? Number one, it consists of dead liver cells. It consists of dead liver cells, RBCs, and necrotic material. Pus may be green due to bile mixture, but no WBCs over here. Pus may be green due to bile mixture, but important thing to note over here is no WBCs in the pus. कोई भी WBC नहीं होगा पस में, because there are no hepatocytes consist of Kupffer cells as an protective or the phagocytic agent over there. So WBC is not able to be the composition of this pus, not able to be the part of this remarkable pus which is found inside the liver. Okay, so we will look towards the composition or the course and sequelae or the fate of this liver abscess. What happens, what sometimes it can also get calcified sometimes, as we know that the pus is inside the liver, and gradually or eventually there is formation of capsule outside this pus. So sometimes this capsule get calcified also, and maybe it may not present as chronically or in as Hmm, maybe it gets subsides inside the liver, calcified the liver as the immunity of the patient takes upper hand. It may subsides there, or the amoebic, or by the use of drugs or various medications that we give for amoebiasis, it may get subsides. But most of the time it also causes complications and presents acutely. So we will look what are the complications produced by, or what are the sequelae of this amoebic liver abscess. Okay, so by making a diagram. I will present this. This is the chest wall, or we can say this is the chest wall part, and inside is the pleura. This is the pericardium. This is my lung. Okay, okay. So the liver is somewhere here, and there is pus inside the liver. Is pus inside the liver, or abscess. Amoebic liver abscess, not just abscess. And this is my hepatic duct. This is okay, and maybe this is the gut loop somewhere. No? So what happens? What can happen from here? I will see to it that this is my pericardium. This is my heart. Okay, and this is the pericardium. Near outside the heart, everyone knows it. This is the pleura. These are the lungs. Okay, so from here, where it can go? So number one, it can rupture into the lungs, leading to the expectoration or chocolate colored sputum, resulting in natural regression of the abscess. So if it goes to the lungs, from here, first can goes to the lungs. If goes to the lungs, it can lead to the this anqui sauce comes out through the alveoli, bronchioles, and bronchus through our mouth, and we can it can come with out with sputum. So it can regress in that way. It is not a dread complication of this, but yeah, it is the one of the fate of this pus. It can goes to lungs, it can go to the pleura. Pleura leads to production of pleural effusion and empyema. Empyema. Okay, so we can drain this. The management over here will be the chest tube insertion, and we can drain it. Okay, cool. It can also go to the bare area of the liver. It can rupture into the bare area, which is just behind here, and it can go to the peritoneum, causing bare area. Liver can peritoneum, causing peritonitis. Okay, and 10% it occurs. 10%. Most of the times it go towards the lung, and leads to the 75% of times it goes into the lungs. That is important to note. 75% times. And it can rupture into the bronchus, causing bronchopleural fistula, leading to various other. This is also comes in the lung part also. Bronchus, causing bronchopleural fistula. Okay, and rupture into the intestine or into the skin. If it ruptures directly from that is what I was telling you earlier. Ruptures into the skin it is known as amoebiasis cutis. It is important. The most dangerous complication, rupture into the pericardium, that I have never till now I have not mentioned. Pericardial rupture leads to cardiac tamponade. which is very dreadful. Okay, so it can also leads to the septicemia, or we can say that if it ruptures, it leads to septicemia, liver failure, and cirrhosis of the liver. Hepatic encephalopathy it can cause. It can also lead to Budd-Chiari syndrome. So liver, hepatic failure, septicemia, and Budd-Chiari syndrome. Really, everyone knows Budd-Chiari syndrome. It is nothing but the compression on the hepatic veins or inferior vena cava leads to the obstruction of the or flow obstruction to the flow of blood towards the heart, leads to the decreased cardiac output and various heart related complications, and the obstruction leads to a raise in intraportal vein pressure and various other complications related to that. So this is what it can, this these all can be the fate of this amoebic liver abscess. It can also, I told you, it can goes to this intestine, go to peritoneum, leads to peritonitis, can affect this area, drain in this bile, and leads to obstructive jaundice and various other features related to this. Now clinical features, how the patient presents if having amoebic liver abscess, how they presents to us. Number one, it is common in males, which is important point to note over here. Very rare cases or very rare conditions having this feature, that it is common in males. Common in males. 10 is to 1. Male to female ratio of having this abscess is 10 is to 1. So this is an MCQ. The reason behind this is I don't know. I am still searching for it, and as soon as I will get it, I will definitely tell you all. So the presentation is, as you all know, the nippus or an inflammation in the body presents with fever, as it is a chronic condition, long-standing disease, so loss of weight. Fever will be intermittent, chills will be there, rigor will be there, and non-productive cough, as it productive cough as it irritates the diaphragm, cough, and shoulder pain. It is the presentation when the abscess is inside the liver only. For various other dissemination and amoebic liver abscess spread, it may present accordingly, which I told you. So pain in the right hypochondrium is 30% people. Right, hypochondrium. 30% people present like this only. And soft and when we palpate, on palpation, liver will be soft, liver will be soft, tender, and smooth borders. 70% presents with this, 30% may not. Okay, intercostal tenderness may be present, which is a clinical sign for this intercostal tenderness on examination. And mild jaundice may be present, and deranged albumin, mild jaundice. And when we go for hematology investigations, there may be increased WBC count, ESR may be raised. Okay, and anemia may be there, it is a chronic condition, RBC count may go down. And important point to note, the albumin, the LFTs may be deranged. Okay, and the serum protein, that is albumin, may be down. Okay, so these are the presentation. So now when we are investigating the patient, or And the prothrombin time, as we are PTINR may be deranged as it is liver. Serum ALP, LFTs में हम SGPT may be deranged. Important. Now, after these investigations, we are able to understand that there is something chronic is going to the patient. So there may be some infections. So the next step will be, if the patient is complaining of pain abdomen, next step will be USG abdomen. And from this clinical scenario, we are not yet getting the actual diagnosis. From this scenario, we can make some differential diagnosis. DIFF, differential, differentials. Okay, so what are they? Maybe it is acute cholecystitis, but acute cholecystitis, it may be acute cholecystitis. It may be acute presentation of HCC, hepatocellular carcinoma, due to the hemorrhage or necrosis over there. It may be subphrenic abscess, or it may be pyogenic liver abscess. So the order will be like this: 1, 2, 3, and 4. Okay. Okay, so these all are differentials. Now we will jump into the USG, as we usually do. So USG is the 90% sensitivity, having 90% sensitivity that it will diagnose that something wrong will be there in the liver, and it may be liver abscess. Because there is altered echogenicity, it is anechogenic or hypoechogenic in size. So we can from 90% sensitivity and from USG abdomen we can get size of the abscess, location of the abscess, number, and nature of the liver, nature of liver parenchyma, how it affects them. Chest x-ray, we always do chest x-ray, and chest x-ray findings may be raised diaphragm may be there. There may be pleural effusion, as I told you, it has more complication, and soft tissue shadow may be there. Rarely we can find. Really. Okay. Now the next step, if we are not satisfied with our ultrasound, whereas it is user dependent. Okay, so ultrasound report, we can move forward for CT scan, but it doesn't make any difference in our diagnosis, as it is having 95% sensitivity only. So the gold standard for diagnosis is for diagnosis is USG, and the investigation of choice is USG guided aspiration or single time aspiration, and after that laboratory prove or the lab diagnosis of that person or that aspirate is the uh, definitive diagnosis. So these all are the diagnostic tool. After this, when we once suspecting that it is having a amoebic liver abscess or the abscess is amoebic, we can also perform a sigmoidoscopy. That is the main source. As earlier, as the amoebic liver abscess occurs only after the invasion of the cecum or the rectosigmoid junction. So sigmoidoscopy is the next, or we can say colonoscopy is the next. It is used to identify the active ulcers and scraping of the ulcer. It helps to find the active ulcers we can scrape from the ulcers and get trophozoites. Trophozoites we can get. Now, next important thing, which is also a radiological diagnosis, is technetium 99 scan, and or we can say tech 99 nuclear imaging liver scan. It helps in differentiating the amoebic abscess from pyogenic abscess. How? As the amoebic abscess do not contain WBCs. Okay, amoebic abscess shows cold lesion with hot rim. So when we give this dye or this technetium 99, we can differentiate amoebic abscess from the this pyogenic abscess. As how? Because the when we look at it, it is present as hot rim. Pyogenic abscess is cold abscess is amoebic liver cold lesion because no WBC and rim enhancement in Tech 99 scan. On the other hand, WBC is present, so whole lesion seen as hot lesion. Okay, this is pyogenic. This is amoebic. Okay, so these two we can differentiate with this. Now there are various other tests. Indirect hemagglutination, this is also a part. IHA, indirect hemagglutination, ELISA, all these we can do. And diffusion preparation test, various other tests are there. And now once we and we can detect the serum antibodies of serum rich E histolytic protein and galactose specific adhesion test. Various other tests are there, but we don't go for this all. We see the abscess, we directly drain into or aspirate in, or before this we start the prophylactic treatment, or we can say direct treatment, because after the technetium 99 scan or we sigmoidoscopy we can confirm that this is the lesions are or the trophozoites once get confirmed after sigmoidoscopy or the presence of pus in the liver by doing USG. So we can definitely, or we are sure that it is the amoebic liver abscess. So we directly starts the treatment with drugs. Like first we go for drugs, tablet, metronidazole 800 mg TID. Okay, this is the tablet for how many days? 10 days. Okay, we can go for metro injection metro. We can also give 500 mg TDS for 10 days. Okay, we can give number second tinidazole tinidazole which is 600 mg BD for 5 days. Okay, so these all are the drugs, or we can also give oral or other antibiotics like cefotaxime, ciprofloxacin, amoxicillin if the abscess is small less than 3 centimeter. Other like cefixime, ciprofloxacin, amoxicillin, if the size is less than 3 centimeter, less than 3 centimeter. Okay, other drugs we can use is diethyl dihydroamidine, and also chloroquine is also effective, but we, as due to the presence of various side effects, we are not using this. Now the second step we go for is aspiration. Aspiration of the abscess. Aspiration. Aspiration of the abscess. Indication of aspiration. When we will go for aspiration, okay, because not every abscess or every person is every patient is a candidate for aspiration. If the abscess size is 10 centimeter more, number one, the infected secondary infection is infected abscess, secondary infection is there, other than amoeba, and failure of drug therapy. For 10 days we try these drugs. Failure of drug therapy. If the abscess in the left liver lobe abscess, because of the chances to more chances increase risk of pericardial rupture. So we don't want a pericarditis or cardiac tamponade for the patient. So before that we aspirate it safely. Or seronegative abscess. What is seronegative abscess? Seronegative abscess and abscess in pregnancy, as the drugs cannot be used in pregnancy. Okay, these are the some of the uh, indications. What we do is USG guided. Everyone knows. Under the USG guidance, we take wide bore needle and we aspirate. Before that we confirm PTINR of the patient. If it is deranged, we give vitamin K, IV, or FFP. So USG guided aspiration. Pus is sent for trophocyte study. Okay, and before this we correct PTINR by vitamin K administration or FFP. Okay, or what is the site for the needle if we don't have USG, or this practice is not done in these days. But before the advent of USG or before the advancement, what we used to do is we aspiration is done by passing needle in mid axillary line in the sixth intercostal space. This is blind procedure, although mid axillary line. One USG must be there beforehand to know the size or the extent of the pus, but still it works most of the times, because the most common site for this is segment number 8. Okay, and USG guided if the pus is of yeah, or the size of the cavity is much bigger, or the pus cannot be aspirated in single time, so we can also put a pigtail catheter in the abscess cavity. Okay, if there is thick pus or multiloculated abscess or multiple abscesses procedure, we can also put a pigtail. Now what is the role of surgeon over here? Surgery. Role of surgery, where we open up the patient. Okay, when we will do that, if the even after repeated aspiration and percut percutaneous drainage, pus still comes or cavity fills again. It may happen. Cavity. The pus is thick pus, not coming out through aspiration, not coming through pigtail. If the pus is multiloculated, multiple locules are there, more than two or three. Okay, and left lobe of the abscess if involved, left lobe if involved. Okay, if the pus get ruptured, as I earlier told you, if it can make ways to different areas. The pus in the caudate lobe, as the IVC is near it, will go for surgery. Multiple abscesses, not only one segment of the liver is affected, multiple abscesses in the liver. So there are 1, 2, 3, 4, 5, and 6 indications for surgery, and the procedure is done through the transperitoneal approach. Most commonly we give paramedian incision. This will be our incision most commonly. And in this way we reach the abscess. This is the incision by paramedian incision, and we can after opening the peritoneum we can directly see the abscess. We can place a Malacot catheter inside it or various drains inside it, keeping the drain in situ, and in this way we can manage it. And follow up of the patient. Now after the complications may occur, anesthesia problems, bleeding, as we are dealing with the liver, so various other complications related with liver, bile, and the area around. Okay, laparoscopic drainage is also tried, and it is also very successful. Now how will follow up the patient? Follow up of patient, we keep the drain in situ until the outrain output is less than 20 cc or 25 cc or less than that. And also we will also uh, do the USG assessment before discharging the patient, or we can discharge the patient with drain in situ, and we can proper counsel the patient to avoid alcohol, repeat LFTs, PTINR, and other things. Okay, and repeated USG is also important. So we will follow up with LFTs, PTINR. Okay, and repeat USG assessment. Okay, now prognosis of this disease. Prognosis is mortality is 4%. Very rarely occurs with rupture into the pericardium. Poor prognostic factors are rupture, serum bilirubin. Poor prognostic features क्या क्या हो सकते हैं? If the rupture, if the abscess get rupture, so it is a mess. And bilirubin more than 3.5 milligram percent, albumin less than 2.0 gram. Okay, because in these cases we have to give corrections, and it takes time to correct all these things. Liver failure, if the patient, cirrhotic patient, multiple abscess, है ना? And the volume of abscess if more than 500 ml. If the patient is with comorbidities, comorbid patient, for example diabetes, है ना? And anemia and all other feature, all other things. So these all are poor prognostic indicators. So thank you very much.